Most models of well-being typically only revolve around 1 to 3 domains, sometimes 4 if you're lucky. And these domains are aspects or systems that impact an individual's well-being. Systems theory says that the systems that an individual functions within are the primary element as to why their behavior is the way it is. Systems are essentially relationships that the individual is impacted by. Now, these systems can be interpersonal, human to human, groups, families, friends, work, healthcare between patient and doctor. Systems can also be internal. This can be the way the relationship the mind has with the body, with disease, with pain, with sickness, whatever the case may be. There are some models and theories and whatnot that attempt to resolve problems within these systems, such as marriage counseling, couples counseling, families counseling, group therapy, and occupational therapy, just to name a few. However, they only work within a certain number of domains, generally 1 to 3, maybe 4 if you're lucky. Now, most models of well-being, such as healthcare, mental health care, behavioral health care, family systems, occupational, group, and even educational models for well-being, typically focus on, similarly, on 1 to 3, maybe 4 domains. Person-centered therapy is also one of these, even though it is broadly used within counseling and is the core for the counseling profession. It still only focuses on, I think the maximum number is 5 domains. Neurodiversity-Affirming Therapy is one. Trauma-informed approaches are one. Collaborative proactive solutions model is one. And if you haven't heard collaborative proactive solutions, it was developed by Dr. Ross Green for use within schools. And it relies on Plan B. Now, Plan B is how you work with other individuals in order to solve problems. Basically, the adult pulls a child in or off to the side, whatever, just you and them. And the adult says, I've noticed you've been struggling in this area. And then it asks one simple question, what's up? Then it involves the adult listening to the child and collaborating to work out a plan to resolve an unsolved problem, as it were. There are, of course, others, such as recovery citizenship, which focuses on the system of the individual inside the community. So it focuses on the community. So collaborative proactive solutions, as I mentioned. It focuses on the system of the child within the school or the classroom or within the family. Occupational theory or occupational therapy focuses on the system of employment, occupation, what or how the individual is going to interact with the occupation and vice versa, how the occupation is going to impact the individual. Now, there are other models that focus on the individual rather than the system. There's person-centered therapy developed by Carl Rogers, which focuses on the domains of relational safety, autonomy, support, identity integration, understanding or emotional literacy, as it were, and intimacy and connection. It has a limited focus on accessibility, sensory ecology, and community participation. But it says that authenticity, empathy, unconditional positive regard are self-directed growth, or promotes self-directed growth. Attachment theory is another one that, though it involves the system of the family or primary caregiver and the individual, it focuses more on the individual. It functions off the primary domains of relational safety, nervous system balance, intimacy and connection, and identity integration, with some secondary domains of belonging and reality integration. The contribution that attachment theory has is safe relationships as the foundation of development. Trauma-informed care focuses on the domains of relational safety as well as autonomy support, nervous system balance, and reality integration, with some secondary domains of identity integration and belonging. It contributes understanding of how trauma impacts safety, regulation, and meaning-making. Neurodiversity-affirming therapy, or care practice, however you choose to say it, which is highly promoted by the neurodiversity-affirming community. This operates off the domains of identity integration, accessibility, autonomy support, and belonging, with some secondary domains of sensory ecology and communication reciprocity. Its contribution to healthcare and practice is that human variation is natural. Environments should adapt to people rather than people adapting to the environments. Now, once again, we have collaborative proactive solutions, which revolves around the primary domains of relational safety, communication, reciprocity, and autonomy support, with some secondary domains of understanding and belonging. Its contribution is that people do well when they can. Collaboration over compliance. DBT, dialectical behavior therapy, functions off the domains of nervous system balance, communication, reciprocity, and understanding, with a secondary domain of reality integration. Its contribution is emotional regulation, distress tolerance, mindfulness, interpersonal effectiveness. Acceptance and commitment therapy, or ACT. The primary domains that it operates under are identity integration, understanding, and autonomy support, with secondary domains of reality integration and developmental restoration. Its contribution is a values-based living and psychological flexibility. Narrative therapy. Primary domains it operates under are identity integration, understanding, and reality integration, with secondary domain of developmental restoration. It contributes to the understanding that helping people reconstruct personal narratives. Recovery-oriented care. Primary domains: belonging, community participation, autonomy support, and identity integration, with secondary domains of developmental restoration. Contribution, hope, citizenship, meaning, and participation. Community psychology. Primary domains: community participation, belonging, accessibility. Secondary domains: autonomy support, contribution. Well-being emerges from communities, not merely individuals. Universal design for learning. This is an educational model. It operates off the domains of accessibility, communication, reciprocity, autonomy support, with secondary domain of belonging. It contributes that design for human variability from the outset. Basically says that people learn in their own ways. Occupational therapy. Primary domains: accessibility, sensory ecology, community participation. Secondary domain is autonomy support, contribution, environmental adaptation, and meaningful participation. Disability studies. This basically operates off of the social model of disability. Primary domains are accessibility, belonging, autonomy support, with a secondary domain of identity integration. Contribution: social model of disability and barrier reduction. Developmentally restorative education. This is an educational model that helps restore an individual's developmental stages. Primary domains are developmental restoration, belonging, understanding, with secondary domain of identity integration. Contribution: development can resume throughout the lifespan. When we say development, we mean the multiple different developmental models, whether it be Freud's psychosexual model, or Erickson's psychosocial model, or any of the others. Recovery citizenship theory. Primary domains: community participation, belonging, identity integration. Secondary domains: accessibility, contribution, citizenship, rights contribution, and social inclusion. Now, as you see, all of these different models and types of therapy and theories only function off of a few domains that promote human understanding and well-being. Further, these domains only impact certain parts of the brain. However, this guy right here developed his own model for education, which I really enjoy and use in my therapeutic practice. The primary domains that Fred Rogers' educational philosophy focuses on are relational safety, belonging, emotional literacy or understanding, developmental restoration, and intimacy and connection, with limited focus on accessibility, sensory ecology, and reality integration. The contribution that he had was that the idea that human needs are legitimate and that development occurs best within safe, accepting relationships. Stay tuned for part 2, when I dive into a new model that I am currently developing. Now we get to the point. am currently developing a therapy and education model, healthcare model as well, that focuses in on all 12 domains of human flourishing. These 12 domains are areas in a human being's system, or as I like to call them, neighborhoods, as promoted by this guy. And these domains promote human flourishing. As we said, that most models and theories only work within a couple of these. But this model works through all 12. It started out with 11. As I began using it in practice, I began to realize we needed a 12th model, or a 12th domain. Starting out, Originally, it was felt that 2 sessions per domain was suitable. As I began rolling it out, I realized that some clients may need more sessions. So 2 to 6 sessions per domain, depending on the client, maybe even more, depending on how strong their needs are. And for a typical client, we would go through it in order. However, I am also working on a intense trauma approach to help, where individuals who experience intense trauma, or also individuals who have high psychosis needs, will likely go through these in different orders. Now, that doesn't mean the trauma approach is going to be the same as the psychosis approach or vice versa. No, we need to reorganize these in order to fit the needs of the individual. So as you can see here, domain 1 is relational safety, autonomy support, nervous system balance, sensory ecology, developmental restoration, communication reciprocity, identity integration, accessibility, intimacy and connection, understanding, which, as I said before, is emotional literacy, belonging, and reality integration. All too often, we tend to go in to seek help, whether it be from a doctor, a psychologist, psychiatrist, counselor, social worker, whatever the case may be, maybe even a teacher, because we know something is preventing us from flourishing. We just can't pinpoint exactly what it is. We know we're different. Many of us who are neurodivergent have felt this way our entire lives, but we can't quite pinpoint what it is about us that needs work. We feel alien, like we don't fit in. And that's where the domains come in of the neighborhood model of neurorestorative care. Now, in counseling and social work, there are different therapeutic models and theories and whatnot that clinicians try to see if they help. And most of those models tend to focus on certain domains. In education, there are others, educational models that focus on specific domains that attempt to help individuals learn. And as we know about education, there isn't a one-size-fits-all approach. As much as teachers and administrators would like there to be, there's not. We all learn differently. This is where universal design for learning comes in, UDL. It basically states that human variability matters. No one learns the same as another person. It's designed to meet human beings on a very human level, to determine what their needs are and to help them learn in their own way. The primary domains that UDL focuses on are accessibility, communication reciprocity, and autonomy support, with a secondary domain of belonging. Mr. Rogers went another direction, which is why he is such a huge core feature of my model, the neighborhood model of neurorestorative care, because he added domains. His contribution was the idea that human needs are legitimate and that development occurs best within safe, accepting relationships. And that's very, very important. The primary domains that Mr. Rogers' educational philosophy focused on are relational safety, belonging, emotional literacy or understanding, developmental restoration, intimacy and connection, with limited focuses on accessibility, sensory ecology, reality integration. Collaborative proactive solutions developed by Dr. Ross Green, as mentioned in my previous video, blends the educational and the therapeutic models together. As I talked about in the last video, it's about children doing well if they can, not if they want to. It's about collaborating and using Plan B to assist the child in developing unlearned skills. The contribution that CPS has is that people do well when they can. Collaboration over compliance. Primary domains that CPS focuses on, though, are relational safety, communication reciprocity, autonomy support, with some secondary domains of understanding and belonging. So as you can see, just in those 3 educational models or philosophies, there's very limited reach when it comes to the domains that they focus on. Mr. Rogers focused on the majority of the domains, the most. Universal Design for Learning attempted to, but it only really focused on variation, accommodation, accessibility, and the such.
As you'll see in different therapeutic models, they kind of follow the same path. Person-centered therapy was developed by Carl Rogers, and it is the primary focus of the counseling profession. It is essentially the spine of the counseling profession and how our counseling industry as a whole develops. And the contribution that person-centered therapy provides is authenticity, empathy, and unconditional positive regard, along with self-directed growth. Primary domains that person-centered therapy revolves around are relational safety, autonomy support, identity integration, understanding, and intimacy and connection, with limited focus on accessibility, sensory ecology, and community participation. As you can see, person-centered therapy tries to match Mr. Fred Rogers' educational philosophy in the number of domains that it impacts. Attachment theory is one that I've really enjoyed learning about over my educational years and even now. And attachment theory's contribution is that safe relationships as the foundation of development, basically restoring attachment between an individual and their support system or their caregivers. And the primary domains it focuses on are relational safety, nervous system balance, intimacy and connection, and identity integration, and secondary domains of belonging and reality integration. And this can be just as important for adults as it is for children to engage in, because many of us endured severe trauma in childhood, especially if we were neurodivergent. We were often left to our own accord. Our parents couldn't really handle us. They didn't know how to connect to us, whatever the case may be, whether it be abuse, neglect, whatever. Adults can benefit from attachment theory as well. Trauma-informed care is another, and its contribution is understanding how trauma impacts safety, regulation, and meaning-making. The primary domains that it encompasses are relational safety, autonomy support, nervous system balance, and reality integration, with secondary domains of identity integration and belonging. Trauma-informed care is very important, especially in community-based behavioral health, because as a clinician in community-based behavioral health, I see a lot of clients with trauma. Trauma-informed care is just as important as person-centered therapy and attachment theory in my realm, as well as neurodiversity-affirming therapy, which I'll touch upon here in a moment. So neurodiversity-affirming therapy contributes the idea that human variation is natural and environments should adapt to people. The primary domains it encompasses are identity integration, accessibility, autonomy support, and belonging, secondary domains of sensory ecology and communication reciprocity. Now, these make the core of my model, the neighborhood model of neurorestorative care, along with collaborative proactive solutions and Mr. Rogers' philosophy on education. There are still others, though, that clinicians provide that I've folded into the model as well. And many clients, many individuals, many neurodiverse individuals have experienced some of these forms of treatment. You have dialectical behavior therapy, which is DBT, and its contribution is that emotional regulation, distress tolerance, mindfulness, and interpersonal effectiveness are important. Its primary domains are nervous system balance, communication reciprocity, and understanding, with a secondary domain of integration. Many neurodiverse populations, people, individuals, say that DBT doesn't really work for them, or have concerns of how DBT can work for them. When I started doing therapy, I used this workbook a lot with my neurodiverse clients, and it helps. It works within our sensory ecology to help develop skills. Then there's acceptance and commitment therapy, or ACT, which is one I like to use for developing skills to prevent rumination or to combat rumination. And its contribution is a values-based living and philosophical flexibility, with primary domains of identity integration, understanding, and autonomy support, and secondary domains of reality integration and developmental restoration. Narrative therapy contributes to helping people reconstruct personal narratives, with primary domains of identity integration, understanding, reality integration, and secondary domain of developmental restoration. Narrative therapy is very limited, but it does have a strong presence when it comes to reality integration and understanding. Recovery-oriented care, which is the primary focus for substance use. It contributes hope, citizenship, meaning, and participation, with primary domains of belonging, community participation, autonomy support, and identity integration, with a secondary domain of developmental restoration. Community psychology is one of those systems psychologies or group psychologies, with a contribution of well-being emerges from communities, not merely from individuals. Primary domains are community participation, belonging, accessibility, with secondary domain of autonomy support. I already discussed ecological systems theory in my previous video, and it attacks all domains in my model. And its major contribution is that it explains how systems interact to influence development, but it doesn't really provide a way to help individuals who struggle in those domains. It provides structure rather than the domains, actually, but it supports all the domains. Universal design for learning. As I said, its contribution is designed for human variability from the outset, with primary domains of accessibility, communication, reciprocity, and autonomy support, and a secondary domain of belonging. Occupational therapy, which contributes environmental adaptation and meaningful participation. Primary domains of accessibility, sensory ecology, and community participation, with a secondary domain of autonomy support. Disability studies. Contribution, social model of disability, and barrier reduction. Primary domains: accessibility, belonging, autonomy support, with a secondary domain of identity integration. Disability studies is what prompted the development of the social model of disability. It's really helped us improve our understanding, and it is another core feature of my model. Developmentally restorative education, with a contribution of development can resume throughout the lifespan. This is very important because many developmental models, such as Freud's psychosexual model of development and Erikson's psychosocial developmental model, basically state that you have to successfully complete certain milestones in order to move on. And if you don't, you are stuck in that phase of development, or all further development is corrupted. I don't believe that's true. I believe we are fully capable of going back and restoring development in those stages and later on. Now, developmentally restorative education focuses on the primary domains of developmental restoration, belonging, and understanding, with a secondary domain of identity integration. You also have recovery citizenship theory, which contributes citizenship, rights, contribution, and social inclusion. Primary domains focused on in this are community participation, belonging, identity integration, with a secondary domain of accessibility. The clinical implications of the neighborhood model is that the neighborhood model encourages clinicians to assess not only symptoms, but also the conditions surrounding the individual. Clinical assessment focuses on sources of belonging and exclusion, safe and unsafe relationships, sensory environments, accessibility barriers, identity development, community participation, and opportunities for continued growth. The model may be applied in therapy, education, healthcare, community programming, organizational consultation, and systems-level intervention. The central proposition for the neighborhood model is that the neighborhood model of neurorestorative care proposes that human flourishing emerges when people inhabit environments characterized by belonging, relational safety, accessibility, identity affirmation, communication reciprocity, autonomy support, meaningful participation, and opportunities for continued developmental growth. People often heal not because they are fixed, but because supportive environments allow development, connection, identity, and participation to resume. In this view, healing is not merely the reduction of distress, it is the restoration of conditions that allow people to continue becoming. So as I said, this is a working model that I'm currently developing. I'm incorporating it into my individual and group therapy, developed a number of different activities that I use in groups as opposed to individuals. I'm also figuring out what works and what doesn't, what needs strengthened, and what needs removed. Again, this started out with 2 sessions per domain, and it's moved just within the first domain of using it. It's moved to 2 to 6 sessions per domain. And it also added a 12th domain rather than just sticking with the original 11. I'm currently finding different things that need to be included. There are always gaps. There's always things that work and don't work. And by incorporating this into practice now during the development, it becomes less theoretical and more active, that it can work. Now, I'm also writing a paper to go along with the neighborhood model, and I plan on writing a article for some different therapeutic magazines and whatnot, Counseling Today, Psychology Today, and stuff like that, talking about this model. It's going to be a little while before this paper is fully done, because I want to make sure I have the chance to go through all these domains with individuals and groups to
show that it can work? And if it doesn't work, why?